Once again, I would like to bring everybody's attention that in the chat there is the link to the disclosure slides and the information how to get the continuing education credits for CME and for CNE. Please don't forget to copy this information. And also the sign-in instructions were sent to you guys. Don't forget to sign in this meeting. And I'm passing the floor to Dr. Smith, and he's going to start and share the screen now. Thank you, Dr. Smith.
Thank you. Okay, so this should work here. Okay, you should see a title slide. Is that correct?
Yes, that's perfectly correct.
Okay, perfect. I'll show my disclosures again. These are all my relationships with industry. The one most related to CAA is that we are a site for a clinical trial in CAA that I'll explain at the end of the lecture. And so I administer a contract between the trial sponsor, Alnylam Pharmaceuticals, and the University of Calgary. And this talk will be about cerebral amyloid angiopathy, a disease that continues to fascinate me with all the various consequences on the brain and clinical manifestations. And so I will go over some of those today. So to start a discussion on the pathophysiology, and I apologize, this figure is kind of has tiny print and is very busy, but because we're on Zoom, hopefully you can see it okay on your computer screens. And I'm just going to walk you through this. So cerebral amyloid angiopathy is caused by deposition of beta amyloid in the walls and the adventitia of small arteries and around the capillaries in the brain. And so we're going to start with a neuron here, and this is a blowup of the plasma membrane. So the amyloid beta is derived from the amyloid precursor protein, or APP, which is a transmembrane protein. Function unknown. You can knock it out in a mouse, and the mouse is not embryonic lethal. It develops mostly normally, just with some mild neurodevelopmental anomalies. So we don't know its physiological role. We know that it can be cleaved by different proteases, including an alpha and gamma protease that produce amyloidogenic peptide fragments. If it's cleaved by an alpha secretase, you get a non-amyloidogenic fragment. These amyloidogenic fragments derived from the beta and gamma secretase cleavage come in a family of different lengths, ranging from 37 amino acids to 43 amino acids long. And so the subscript refers to the peptide length. So A beta 40 refers to amyloid beta, that's a peptide that's 40 amino acids long, and A beta 42 is 42 amino acids long. The less soluble 42 amino acid fragment, if it's not cleared from the brain, which we'll discuss in a moment, it begins to aggregate and then form amyloid. So first as dimers, then oligomers, then it begins to form amyloid protofibrils, then fibrils, and deposits in the brain in the form of the senile plaques that are the hallmark and definition, really, of Alzheimer's disease. The more soluble 40 peptide length fragment tends to be less predominant in the senile plaques, but this fragment can reach the perivascular space and deposit in the walls of blood vessels to form vascular amyloid, which we refer to as cerebral amyloid angiopathy. And this amyloid deposition is toxic to the vessel wall and leads to loss of smooth muscle cells, hyalinization and collagen deposition, eventually leading the vessel wall to be brittle and to form cracks, leading to hemorrhages. Small hemorrhages can be silent and detected on MRI as microbleeds, or bigger ones as hemorrhagic strokes. And this can occur both in vessels within the brain to cause intercerebral hemorrhage. It can affect the vessels on the surface of the brain to cause convexity subarachnoid hemorrhage, or silent evidence of past subarachnoid hemorrhages visible as cortical superficial siderosis. So another component of the pathophysiology is that in Alzheimer's disease, the amyloid plaques, through mechanisms not entirely clear, cause neuronal dysfunction and buildup of intracellular deposits of the tau protein, which is a cytoskeleton-associated protein. We think it reflects the fact that the neurons are getting sick, and the tau comes in different repeat forms in different lengths. But this is another feature of Alzheimer's disease pathophysiology, and the tau tends to build up in later stages of the disease as the patient is getting symptomatic. And the tau can be seen on histology, but can also be detected on lumbar puncture or with highly sensitive methods from plasma as well. So there are great advances happening in plasma diagnostics for Alzheimer's disease related to detecting small amounts of CNS-derived tau in plasma. And what's beginning to emerge as well is that you also see tau deposits around blood vessels affected by CAA. And it's not clear where the tau is coming from or where it's derived from, but can be seen on histochemical studies, and also maybe a feature of CAA as well. And so this is something that my research group is looking into. We have found that you can detect abnormal levels of A beta and tau in the blood in people with CAA, in addition to the CSF. And so this might be a way of getting a clue that a patient has CAA, and these are some of the scatter plots shown here. So for example, if you look at the A beta 42/40 ratio, whether it's by mass spectroscopy on the top or single molecule assay, which is a highly sensitive type of ELISA on the bottom, you see that there's a lower A beta 42/40 ratio between CAA. This is about 40 patients with CAA and about 60 controls. And this is in plasma, not in CSF. In the figures on the right, you can also see that there's elevated p-tau 181 in the blood in CAA. There's also elevated neurofilament light, which is a nonspecific marker of brain injury compared to controls. Each of these individual markers has like moderate discrimination between CAA and controls, but if you use a panel of the four markers, A beta 42, 40, p-tau, and NFL, you can discriminate CAA from controls with an AUC of about 0.9. So that's beginning to be useful for individual diagnosis. The challenge with the plasma markers, of course, is this profile overlaps with the profile that you see in Alzheimer's disease. So it looks like we can separate CAA from controls, but we don't know to the extent to which the signal is driven by AD accompanying CAA or AD without CAA. So this is one of the active areas for my research group, is to try to find markers in CSF and plasma that can discriminate between AD and CAA, which is a more challenging problem. But you could imagine that the absence of this profile could exclude CAA in a patient with a potentially compatible syndrome, and that may be clinically useful, as we'll discuss further. Okay, so that's kind of cutting edge plasma diagnostics in CAA. I'm going to go back and focus on the more tried and true ways of diagnosing CAA, which are through CT and MRI, and ideally applying the Boston criteria, which are the most sensitive diagnostic criteria. So I'll thank Andreas Heridamu for loaning this slide to me. And this summarizes the Boston Criteria 2.0, which were published in 2022, and an update on criteria published in the early 2000s and then modified in 2010. So the new criteria specify that to apply them, you should have a CA-compatible clinical syndrome, which could either be a spontaneous ICH or convexity subarachnoid hemorrhage too, for that matter. Transient focal neurological episodes, which I'll define in detail later, or cognitive decline or dementia. The person should be over age 50 because aside from some very rare genetic causes, as well as iatrogenic CAA, which I'll come back to later, CAA is a condition that affects older people. So you have a compatible clinical syndrome, a compatible age, and then MRI features that support that CAA is present, which means 2 or more strictly lobar hemorrhagic lesion in any combination. And by hemorrhagic lesion, we mean intercerebral hemorrhages, microbleeds, cortical superficial siderosis, or convexity subarachnoid hemorrhages. Or, and this is new in the blue features are new in the version 2.0 compared to version 1.5 or 1.0. You could have probable CA based on 1 strictly lobar hemorrhagic lesion plus 1 white matter feature, which is severe centrum semiovale perivascular spaces or a multi-spot white matter hypertensity pattern defined as 10 or more spots, which I'll come to and expand on later. And then for those who don't meet probable criteria, they can meet possible criteria if they have more than one exactly strictly lobar hemorrhagic lesion, or they have one of the white matter features. Okay, and so this has expanded the group that has possible CAA. Okay. So these are examples of the hemorrhagic manifestations that can be applied in the Boston Criteria 2.0. So you have lobar hemorrhages, as shown in this example here, where there's a hematoma cavity left over from a prior ACH. And you can see actually there's multiple microbleeds in this person's brain as well. So they meet criteria for probable CAA. Cortical superficial siderosis refers to susceptibility along the cortical sulci that reflect hemosiderin deposition just under the pial surface or in the superficial layers of the cortex. And we think this predominantly reflects past silent subarachnoid hemorrhages or symptomatic subarachnoid hemorrhages for that matter, but it's a sequela of past subarachnoid hemorrhage. And then we have the cortical microbleeds, which are these tiny dots here. Here's an example with like many, many, many microbleeds, but you don't have to have, tens or hundreds or thousands of microbleeds to be diagnosed with probable CA. You really just need 2 or more microbleeds without an alternative cause like hypocoagulability, a familial cavernous malformation syndrome, and that's sufficient to meet criteria for probable CAA. And these are examples of the new white matter features. So severe centrosomatic perivascular spaces, the way you're supposed to look at those is you look at the slice above the level of the lateral ventricles and axial orientation that has the most PVS. And then you count the number in the most severely affected hemisphere in the most severe slice. So in this slice, there's a lot on both sides, I guess, but maybe I'll start with the one on the left. So, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, moving more inferiorly, 20, 21. Anyway, so once you get to 20, that means severe. So there's obviously a lot in either hemisphere, but you just count 1. So in this example, this is an example of someone who meets criteria for that white matter feature. The white matter intensity multi-spot sign, you simply count all the spots across both hemispheres, across all slices. So to zoom in, I'm showing only one hemisphere on one slice here. But, and here I've overlaid my count, right? So already on this one hemisphere, there's a lot. There's already 14. So already I know the patient meets this criteria. So these white matter features are sensitive, like they're commonly seen in CAA, but not universally seen. They are not on their own highly specific, right? We see people with age-related small vessel disease, not due to CAA, that also have many enlarged perivascular spaces, or where you can count many white matter intensity spots. So on their own, they're only indicative of possible CAA. But when they're present, in addition to a hemorrhagic feature, it can make us more confident that, now we know that it's fairly specific and that CAA is probably present. The possible criteria cover a lot of people. So I think if you're looking to rule in CAA and be confident CAA is present, it's better to look at the criteria for probable CAA as opposed to probable plus possible CAA. So this is showing the validation data from the derivation paper in Lancet Neurology that drive the criteria. And they looked at the performance in the derivation cohort of 159 patients from Mass General, the temporal validation. So they looked at an independent cohort of patients from the Mass General that more recently collected. And they also looked at 123 as part of a multi-center external validation. So that would be the external validation then would be the strongest form of validation. So just limiting to the external validation, right, which would be the strictest form of validation, we can see the criteria are good. Sensitivity 80%, specificity 82%. AUC is 0.81, with a high positive predictive value of 94%. So I guess that's the nice thing about the criteria for probable CAA. When people meet the criteria, they are very likely to have CAA, right? The limitation in the diagnostic accuracy is more when they don't meet the criteria. According to the autopsy validation study, some of the patients still had CAA, all right? And the challenge partly is that the hemorrhagic manifestations are a late manifestation of CAA, that CAA can build up and be present in the system before you begin to get hemorrhages or multiple hemorrhages. And so that's why the negative predictive value is not as high as the positive predictive value. Compared to the prior criteria, there's been some enhancement of the sensitivity from 73 to 80%, with overall relative preservation of the specificity with only a mild decrease from 85 to 82%. So we think the new criteria have enhanced the sensitivity somewhat while essentially preserving the specificity. Now, if we look at the most then these criteria were validated in patients with ICH, TFNEs, or cognitive decline. Most of the validation coming from patients with ICH or cognitive decline, those because TFNEs are not fatal. If you look at just the patients with ICH, which is maybe the manifestation most strongly related to CAA, and you limit it to the autopsy data, though, which is where there's so instead of just like biopsy samples, there was neuropathological confirmation by full brain autopsy. So there are 75 cases like that across all the cohorts. And here we saw like a very high sensitivity and specificity, like 90% and sensitivity, 93% specificity, AUC 0.91. So when we apply the criteria to patients with hemorrhagic stroke, they work really quite well. So that's of relevance to vascular neurologists, where mostly we're encountering CA in the form of hemorrhagic stroke. Now, it's interesting, the gain in sensitivity might come with some changes in the prognostic significance of the criteria. And this was shown in a single center cohort study by David Waring's group at University of College London. So he looked at a cohort of ICH patients, of which 47 out of 122 were classified as probable CA by the new criteria, compared to only 36 out of 122 with the old criteria. So the 11 patient difference, these are patients that had met probable criteria by having a single lobar hemorrhage plus a white matter feature, right, instead of having multiple hemorrhages. And then you looked at the prognostic significance in terms of the recurrence rate. So by the old criteria, the recurrence rate was 10.9 per 100 per year. But if you looked at the and if you looked at everybody diagnosed with probable CA by criteria 2.0, the recurrence rate was somewhat lower at 8.5, and that's because the 20 patients that had probable CA only by version 2.0 had a recurrence rate of 0.9 per 100 patients per year. That was the same as non-CA related hemorrhage at 1.0 per 100 patients per year. So the criteria, although they may be more accurate, they may be also picking up milder CAA that is less prone to recurrence. So you have to keep that in mind when looking at patients that have a single lobar hemorrhage only without other hemorrhagic features. They probably have CAA, but their recurrence risk might be lower than patients with CAA with multiple lobar hemorrhages. Now, it's, ideally you have MRI to help diagnose CAA, but that's not always possible. Patients have contraindications, or you may be in a practice setting where CT is really only available, or patients may be too unstable from ICH to have an MRI. So there is information you can extract from CT to increase your certainty that CA is present. And these are based on the Edinburgh criteria, published in Lancet Neurology in 2018 by the group in Edinburgh. And the Edinburgh criteria rely on three features. Two are CT features. One is a genetic risk factor for CAA. So the CT features are whether subarachnoid hemorrhage was present or not, and whether there were second CT features where there are finger-like projections. So subarachnoid hemorrhage out of an example, but this is an example of a case with finger-like projections here, or this one here. So it's where you see, instead of the hematoma being a fairly solid, ball of hyperdensity on CT, you see that it's got these kind of lobules to it, and they seem to kind of like go along and maybe fill up some of the gyri. So they're kind of extending into the lobes, and you have this interspersed, area of hypodensity in between these kind of fingers. It's somewhat subjective, but once you get used to looking at it, there's evidence that radiologists can determine this reliably. And then the third feature, which is a genetic risk factor for CA, was the presence of the ApoE epsilon 4 allele. And with these criteria, you can, if two of the three features are present, you can rule in CAA with high specificity. So you're pretty confident that CAA is present when those two of the three features are present. When all of the features are absent, you can have a rule out sensitivity. So you're pretty confident CA is not present if none of the features are present. Now, the challenge in clinical practice is that, at least in my practice setting, we don't do ApoE genotype testing. If we did, it would take like days or weeks to come back. It's not recommended by clinical care guidelines like AHA guidelines or Canadian guidelines for care of patients with intracerebral hemorrhage. So it's a bit unfortunate that that's a feature. But if you take out this feature, you're no longer able to rule out CA with high specificity anymore. But if both the finger-like projections and the subarachnoid hemorrhage are present, which is this column here, you're still able to rule in CAA with high specificity. So a modified version of this criteria based only on the CT features of presence of subarachnoid hemorrhage and presence of finger-like projections, if both of those are present, you can still be like pretty confident that CA is present neuropathologically. So limitations, it was a small number of studies. I take that, actually, I should modify this. This has been independently validated by another group, and there's ongoing work in a multi-center study to validate it, including looking at its predictive power for future recurrence. And it does seem to validate pretty well. So I would say it has been validated as a way to rule in CAA when those two CT features are present. Now, of course, like the alternate causes of hemorrhage that we're looking into as vascular neurologists are often, secondary causes like vascular malformations that can be excluded with neurovascular imaging or where it's evident on MRI. Most of the hemorrhages we see, and then of course trauma as well can be a cause of hemorrhage that's evident on the history. After excluding those, which are relatively easy to exclude, then we're left choosing between is it CA-related small vessel disease or non-CA-related small vessel disease, which sometimes is described in the literature as hypertensive arteriopathy, which is a bit of a misnomer because we do see patients with intracerebral hemorrhage who don't have a history of hypertension and only have the usual mild to moderate reactive hypertension, but don't have CA either. So not all age-related arteriolosclerosis is due to hypertension. That's not CA, is due to hypertension. You can get arteriolosclerosis and hemorrhage from, aging, smoking, maybe other risk factors, right? But we're often left kind of deciding between these two things. And the reason the Boston criteria work is there are different tendencies for these two diseases to affect the arteries in different distributions, right? So on the left, we have the non-CA-related small vessel diseases, which consist of neuropathologically, you see arteriolosclerosis and lipohyalinosis. Less attention has been paid to this, but you do see disease of the small veins with aging as well, which is a process called venous collagenoses, and it's been linked to progressive white matter hyperintensity development, but less is known about the venous disease. And in the non-CA small vessel disease, well, it affects diffusely the arteries across the brain, but often the penetrating arteries to the pons and to the basal ganglia are affected the most. So you see hemorrhages and microbleeds and lacunes in that location, as well as subcortical hyperintensities and periventricular hyperintensities. And you see enlarged perivascular spaces, usually in both the basal ganglia, more so or in addition to the centrum semio valley. Whereas with cerebral amyloid angiopathy related small vessel disease, you see this predilection for it to affect the superficial parts of the brain. So you'll see microbleeds in a lobar location, hematomas in a lobar location, superficial hemorrhages evident as subarachnoid hemorrhages or cortical superficial siderosis. Um, Intriguingly, you see deep white matter changes as well. Um, and it's not clear what that is. It may be that CA is affecting the penetrating vessels into the white matter as they pass through the cerebral cortex. And because you don't see a lot of vascular amyloidosis in the white matter neuropathologically, yet you see these white matter hypertensities in CA. So it may reflect ischemia in the end zone of these penetrating arteries that have a cuff of CAA at their origin as they're passing through the cerebral cortex, where most of the vascular amyloid deposition is. Vascular amyloid deposition is predominantly in the cerebral cortex, or in the superficial brain and in the meninges, and it also has a more posterior than gradient, so it's more the posterior brain regions are affected more heavily than the anterior brain regions. No one is completely sure why. It may have something to do with bulk movement of CSF and clearance of peptide fragments from the brain. So it may have something to do with the distribution of flow of like water and solutes in water, including toxins like A beta, is people's best guess. But we can use these different distributions to make inferences about the location of, about the presence of CA based on the location of the hemorrhagic lesions. With non-CA arteriolosclerosis, able to affect all the arteries across the brain. And in contrast, CAA, with some exceptions that I'll go through, tends to affect the lobar brain regions and to some extent the cerebellar arteries, but not the non-lobar regions. So one of the exclusion criteria in the Boston criteria is that if you have lesions in the non-lobar locations, you're not supposed to diagnose CAA because it could reflect non-CA arteriolosclerosis. So and that's challenging because about 1 in 6 patients with primary ICH have this mixed pattern of bleeds, and so you're left a little uncertain. Like, is it CAA plus, well, is it non-CA arteriolosclerosis? Although when you see cases like this, where you see like so many lobar bleeds and there's only 1, 2 like deep bleeds, it's kind of hard to believe that person doesn't have CA. And the other solution for mixed disease is that they have non-CA arteriopathy, but they also have CAA. And so we'd like to be able to distinguish between the two. One of our ideas, maybe that's a role for those plasma markers that we discussed earlier. If you can test plasma, A beta, and tau, and they're negative, then maybe you've ruled out CAA, although more validation is needed to understand whether that approach works and whether the prognosis of patients who have mixed bleeds with negative A beta and tau in the plasma, what their recurrence rate is, we don't know at this point. There is some unpublished data that's plausible to me from reanalysis of or additional analyses of the data used to derive the Boston criteria 2.0, that if you have a high ratio of lobar to deep bleeds, and that study, it was 4 to 1 or higher, then it made it quite, then it was almost certain that CA was present neuropathologically. So a case like this where I didn't count them, but there's like, on this slice alone, there's like 25 lobar bleeds probably, or 30, and there's only 2 deep bleeds. So there's like a ratio of 15 to 1. So it's likely that a person like this has CAA, maybe not exclusively CAA, but it's unlikely that they have severe arteriolosclerosis and no CA based on the ratio of lobar to deep bleed. So that work is kind of under review. Might eventually be included in the criteria, but shows that you still need to use some clinical judgment, right, when like looking at these cases to infer the presence of CA or not. Okay, and there are many diverse clinical syndromes related to CA. Like we've talked about intracerebral hemorrhage already, which is maybe the best recognized syndrome. But also related to hemorrhagic disease, patients can have transient focal neurological episodes, also sometimes called, amyloid spells, and I'll define those in a moment. And those are hemorrhagic strokes from either convexity subarachnoid hemorrhage or ICH that are related to the hemorrhagic disease. But there are also these white matter features and also cortical microinfarct. So there's like, and you can also see small silent DWI positive lesions sometimes when you image patients with CAA. So there are also these ischemic manifestations of CAA that we're just beginning to understand more. And when you accrue damage.
Dr. Smith, you're muted.
Okay, I don't know what it is. Some sort of gesture muted me. Sorry about that. Hopefully, I haven't been muted for the last 20 minutes, but because it's hard for me to see the control panel while I'm looking at my slides. Well, let me carry on for where I am. So I was talking about the diverse clinical and radiological syndromes that happen with CAA. And there are the syndromes related to hemorrhagic disease, which are shown on the left here. And let me just get back to my pointer. Okay, which are intracerebral hemorrhage and subarachnoid hemorrhage. So these are well known manifestations of CAA. But you also have manifestations related to ischemic disease from CAA. So in addition to the hemorrhages, as discussed, you have white matter hypertensities, which may reflect ischemia at the end zone of penetrating arteries into the white matter. You have this widening of the perivascular spaces, and you also have small infarcts, which chronically can be seen as infarcts, microinfarcts in the cortex, too small to be seen on MRI generally, but you can see them neuropathologically. And as well, you can see that patients with CA that are imaged sometimes have small DWI positive lesions reflecting acute infarction. These can happen in the lobar regions, like in the cortex or the subcortical white matter. And then finally, not shown on this slide, you can also have evidence of vasogenic edema consistent with vasculitis or perivascular inflammation. That's been termed CA-related inflammation. And CA has been linked to risk for amyloid-related imaging abnormalities in patients treated with amyloid-targeted therapies, lecanemab and donanemab. So let me discuss some of these additional CA-related syndromes. So first, transient focal neurological episodes, also sometimes called amyloid spells, although I and some others who do clinical and research work in CA like this term TFNEs better as being more specific. So, and this refers to a syndrome where there are transient symptoms. They're often recurrent. They can be, they often include sensory symptoms, but can include motor symptoms as well. Usually mild, so not hemiplegia, but it'd be like, and they often spread from one body part to the other, consistent with that we think that the pathophysiology is likely to be cortical spreading depression. So like a classic case would be, some numbness or tingling that might start in the fingers and then go to the lips and the tongue and march up the arm and then last about half an hour and fade away. And there'll be some, in addition to positive sensory symptoms, paresthesias, there'd also be negative symptoms of numbness and often some clumsiness of the fingers or mild dysarthria. So that would be classic. And they can recur in a stereotype fashion. So they can mimic TIAs is the main concern. And these patients often get misdiagnosed with TIAs and put on antithrombotics, but they could also mimic focal seizures, and EEG is generally indicated as well to rule out focal epileptiform activity, which is usually absent if the cause is CA-related TFNEs. They're strongly associated with either an acute convexity subarachnoid hemorrhage, as shown here, which can be subtle, and you need to look really carefully at the sulci on CT or MRI to pick it up on CT or MRI flare, or on susceptibility weighted sequences. And this GRE, you can see that there's susceptibility artifact in this sulcus. People debate, like, do you need to have subarachnoid hemorrhage or CSS to have this syndrome? You probably not, but probably 90 to 95% of cases have evidence of SAH or CSS. They often recur and there's like a wave of symptoms that like crescendo and then plateau and then fade away over a period of like 4 to 12 weeks. So they will resolve spontaneously, but people sometimes add anticonvulsants like Keppra to see if they can be managed or help them go away more quickly. And importantly, there's a similar risk of having a future symptomatic hemorrhagic stroke, either ICH or SCH, as patients that present with intercerebral hemorrhage. So it's a marker of patients at high risk for hemorrhage. So it's important to recognize this syndrome. And the best way to do this is to be aware of the clinical features of the syndrome. And whenever it's potentially possible, this would be a good reason to get an MRI as workup for somebody with TIA, because it's seeing the subarachnoid hemorrhage, the CSS, or the multiple microbleeds consistent with Boston criteria CA that provide the clue to the diagnosis. Another manifestation recognized, after the link between CA and intracerebral hemorrhage is that CA is related to cognitive decline, right? And there may be multiple ways in which this is the case. One could be through the destructive effects of hemorrhages. A second way could be through an association with comorbid Alzheimer's disease neuropathology, because AD pathology is quite it's quite common in patients with CAA, although only about a quarter of patients with CA have a history of dementia or Alzheimer's disease before manifesting CA-related symptoms. But my research and others suggest that CA-related neurodegeneration is an important cause as well, probably driven by altered vascular activity and damage to the white matter. And one reason I say that is because the average neuropsychological profile of a patient with CAA tends to look more vascular than Alzheimer's disease-like. So in this cross-sectional study, we compared patients with CAA to patients with AD, MCI, and ischemic stroke. And the bars represent the deviation from normal in memory. A higher bar indicates like more abnormal. So you can see the pattern in CAA is that the amount of memory impairment in the dark gray bar was less than the amount of impairment in executive function and processing speed. Whereas in Alzheimer's disease, you saw the opposite. You saw the most severe impairment in memory, also impairment in executive function and processing speed, but not as severe as memory. So the profile fits more of a vascular profile. And then in a cross-sectional study where we did a mediation analysis, we found that we could explain most of the relationship between CA and cognition compared to a control population based on the amount of altered cerebrovascular activity and the amount of white matter disruption measured in this case on diffusion tensor imaging. The exception was that lower cortical thickness in regions affected by Alzheimer's disease did explain some of the indirect effect on executive function, but otherwise it was the cerebrovascular activity and white matter disruption that explained most of the effect. Now, there's about almost half of the effect of CA on cognition still remains unexplained. So there are other features we're looking for in biomarkers to help explain the unknown variants. Now, there's also this entity of CA-related inflammation, where you see vasogenic edema, usually in a patient presenting with a seizure or cognitive decline or delirium, also sometimes with focal deficit. So here's an example from my practice. So this someone had a seizure, has a vasogenic edema in the right parietal lobe, which you can see there's white matter hyperintensity on flare that's going up to, but not involving the cerebral cortex, and not shown here. It was bright on ADC, so there's no evidence of diffusion restriction here. So it's not cytotoxic edema, it's vasogenic edema. They had a biopsy done, which is what this cavity here comes from, because they thought there must be infiltrating glioma in this lobe. Contrast enhanced imaging and CA-related inflammation can sometimes show some faint enhancement at the margin or faint leptomeningeal enhancement. So did the biopsy, what the pathology showed was instead of glioma, they found thickened vessels infiltrated by lymphocytes and a positive immunohistochemical stain for A beta. And the patient was treated with steroids, and the scan went from showing a lot of vasogenic edema to probably 80% of it resolved. There's a biopsy cavity left over. And they responded well to steroid pulse, which 80% do. We weaned them off steroids over a period of 3 months. But then a year later, they had a recurrence, and this can happen in about 40%. And so at the time of recurrence, they had another seizure, and you can see the edema's back in the right parietal lobe just like before, but there's additional areas now too. Actually, the left occipital lobe is now partly involved, and a couple of patchy areas in the subcortical white matter and the frontal white matter on the right and left sides as well. So we put them back on steroids and also on a chronic immunosuppressive agent as well, azathioprine. And this syndrome is very similar to what happens if you treat patients with CAA with lecanemab or donanemab, which is a phenomenon called amyloid-related imaging abnormalities, or ARIA, which can take the form of edema, or ARIA-E, with a pattern that looks very similar to CA-related inflammation, or ARIA-H, which stands for ARIA hemorrhage, and is marked by microbleeds appearing or superficial siderosis appearing in the brain, as shown by the arrows here. And so this radiologically occurs in as much as 1 in 4 to 1 in 3 patients treated with lecanemab or donanemab. Patients with more than 4 microbleeds or with superficial siderosis are supposed to be excluded from treatment because CAA is a risk factor for this condition. And patients with lecanemab and donanemab should probably not be treated with thrombolysis if they're having an acute ischemic stroke, because multiple or several cases of intracranial hemorrhage have been reported in that scenario, including fatal hemorrhages. And this was covered in a recent scientific statement from the American Heart Association, which is the reference below. Finally, a very fascinating form of CAA occurs with the iatrogenic CAA, which refers to CAA that can be transmitted by transplantation of human cadaveric tissue from donors that had CAA or Alzheimer's disease, in which case the transplant has been seeded by beta amyloid seeds. And this demonstrates that beta amyloid seeds have a prion-like property where they can catalyze formation of new amyloid from the seed. And so this is an example from my practice. It was a 35-year-old referred by a neurosurgeon because his cognition was declining. The neurosurgeon was following him because as a toddler, he'd had operations for a myelomeningeal seal and tethered cord. And his MRI showed multiple microbleeds, including a left temporal hematoma, many microbleeds. These are tracks of prior VP shunts because he also had hydrocephalus that had managed by shunts and shunt revisions. There's also a thalamic hematoma, interesting, which was described in this syndrome and suggests by others and suggests that CA may not be as purely lobar as we use or exploit in the Boston criteria. And I made the diagnosis by tracking down an operative report from many years ago at the that had shown that he had a cadaveric dural transplant in 1989. And so that cinched the diagnosis. You can also confirm this with like amyloid imaging or plasma testing that demonstrates amyloid is present in the brain, which we like not expected in a 35-year-old, of course. Now, the fear of CA, of course, is that it causes recurrent hemorrhages. And compared to patients with non-CA related ICH, the average recurrence risk in CAA-related ICH is 9 per 100 per year compared to 1.3 per 100 per year. So we have, like more than a 6-fold increase in recurrence rate. So like a really huge difference. And that's why it's helpful to be able to diagnose CAA acutely, to predict prognosis. Within CAA, the patients that are having recurrences, by far the strongest predictor is the appearance of superficial hemorrhages, evident either as disseminated cortical superficial siderosis or acute subarachnoid hemorrhages. And as you can see in these tables, if you once you control for the amount of siderosis and you can further stratify it as focal or disseminated, and you see a graded risk, after accounting for siderosis, actually the presence of multiple microbleeds is not significantly related with recurrence risk anymore. So it's really driven by the amount of superficial siderosis. And this is a dilemma because, patients with CAA, have a similar prevalence of ischemic stroke, cardiovascular disease, and atrial fibrillation as other elderly people, which means it's quite common. And, up to 20 to 25% of patients with intracerebral hemorrhages from CAA have another indication for antithrombotics. So here the clinician faces the dilemma: do I give the antithrombotics to reduce risk of ischemic, cardiovascular, and cerebrovascular disease? Or is it too risky to do so? Am I increasing the risk of hemorrhage from CAA? The RESTART trial gave us information that suggests that restarting aspirin after ICH, if it's indicated for prevention of ischemic cardiovascular disease or AFib, is probably safe. This was a phase 2 study that randomized 268 patients to a strategy of avoiding aspirin versus a strategy of starting or resuming aspirin after an intracerebral hemorrhage. It included patients with lobar and deep hemorrhages, and included those with and without CAA. And as you can see from this Kaplan-Meier curve, the risk for recurrence was low, and actually was slightly, and even almost significantly higher in those who avoided aspirin rather than those that restarted aspirin. So recurrence rate was not elevated, might even be somewhat reduced in those on aspirin. There's an ongoing RCT called Aspire trial that is looking at it's a phase 3 design to confirm these results and also see if aspirin might reduce risk of ICH recurrence, which is kind of a counterintuitive concept. When they looked at subgroup analyses, now it's getting down to very small numbers, so you can see the confidence limits are extremely wide here. But for what it's worth, there was no difference between strictly lobar and non-lobar hematomas, between those with and without superficial siderosis, or with or without diagnosis of CA by Boston criteria, although the confidence limits are so wide, ranging from 0.005 to 157, that we don't have much confidence in these results. But we'll get more data from the phase 3 trial, which is ongoing. And then there's the dilemma. So generally speaking, I'm comfortable with restarting aspirin in patients with CA who've had a hemorrhage. Anticoagulation may be another story. So we had previously data from summarizing the cockroach meta-analysis from a group of small studies suggesting that if you resume anticoagulation after an intracerebral hemorrhage, that you reduce the risk of ischemic events, but you probably raise the risk of hemorrhagic events. And this was confirmed in the Prestige AF trial, so recently published in the Lancet and presented at the last ISC. Prestige AF is the first larger scale trial of anticoagulation versus aspirin or a no anticoagulant strategy rather, in patients who were survivors of an ICH. And so what you can see in terms of the effect on reducing risk of ischemic stroke, you saved about 7.8 ischemic strokes per 100 people per year with an anticoagulation strategy. But the problem is you caused an extra 4.7 hemorrhages per year with an anticoagulation strategy. So now you prevented more ischemic strokes than hemorrhagic strokes that you caused with anticoagulation. The challenge, of course, is that hemorrhagic strokes tend to be worse than ischemic strokes. So we don't know on balance whether this strategy was the right strategy. They were focused on the number of recurrences, not overall disability state or quality of life. So it's a little unclear, again, limited by small numbers, but there was no difference in recurrence rates for hemorrhage in those with non-lobar and non-lobar bleeds, just like the RESTART trial. So that suggests you could maybe consider restarting anticoagulation for someone who values preventing ischemic strokes. But the ENRICH AF trial, which is ongoing, and results will be reported in, I think, a year or two, stopped the lobar ICH arm early because of a safety signal from the DSMB. And we have limited information other than this was announced in a letter to the Lancet, but the lobar ICH arm was terminated in ENRICH AF, suggesting that edoxaban may be less safe than aspirin in that group. So to me, that makes me reluctant to start anticoagulation in someone with a history of lobar ICH. So my own guidance would be for a non-lobar ICH, I'd feel comfortable having a patient-centered discussion about the risks and benefits based on the Prestige AF trial and considering resuming anticoagulation more than 30 days after ICH. For a lobar ICH, until we get the results of ENRICH, I would favor avoiding anticoagulation, either treating with aspirin or considering left atrial appendage closure as an anticoagulation sparing strategy. So those studies were all related to patients with ICH. Now, we also see sometimes patients who get a scan because they have a cognitive disorder or an ischemic stroke. And we see that they have what looks to be a CA pattern of microbleeds and cortical superficial siderosis. So how safe is antithrombotics and anticoagulants in those groups? Well, yeah, my thoughts, along with Andreas's input, are published in Stroke last year, so you can read that paper to get my thoughts on that. But generally speaking, if you don't, because superficial siderosis is the main driver of hemorrhage risk, I would say generally speaking, unless there are many microbleeds, if there's just a few microbleeds, I don't worry about starting antithrombotic, like antiplatelet agents. I would say just go ahead and use antiplatelets if you need to. Same with anticoagulants. If you have many, many microbleeds, I start to get nervous. And if you can select an anticoagulant sparing strategy like left atrial appendage closure, I think it'd be reasonable. I think when cortical superficial siderosis appears, particularly when it's multifocal and disseminated, these patients may have higher risk. And for that patient population, we don't have clinical trial data. So I'll take this all with a grain of salt, but I would consider, minimizing exposure to dual antiplatelet therapy and considering if AF is present in anticoagulation sparing strategy like left atrial appendage closure. Okay, so I'm just going to wrap up in a minute or two. One of the exciting things going on in the field, there have been very few clinical trials in CA, but there is a clinical trial going on now of mivelsiran, which is a small inhibitory RNA that blocks the translation of the APP mRNA into APP and thus reduces buildup of amyloid beta. And this is being tested in both Alzheimer's disease and CAA. The challenge is it does have to be administered intrathecally, or fortunately only every 6 months. And the data from phase 1 studies show that it dramatically reduces the amount of amyloid beta appearing in the CSF, in particular amyloid beta 40 more than the beta 42, with a reduction that's about 67%, or even a little higher for the 50 milligram dosage at 1 month. And then it has a very long duration of effect that's kind of fascinating, and the company has an explanation biologically based on their animal model work. But such that by 6 months, you could feel lost. The half-life's about 6 months. You can dose intrathecally only about every 6 months. So we're one of the participants in this trial, which is, I think, recruited probably about 40 or 50 of 200 people. And the phase 2 trial is looking at appearance of new hemorrhagic lesions as a surrogate efficacy endpoint. Okay, so in conclusion, CA is a fascinating disease with multiple clinical manifestations, including CA-related inflammation, ARIA, and cognitive decline. Boston criteria 2.0 have good accuracy for CA, particularly when you're diagnosing it in ICH patients, and have enhanced sensitivity, but with some sacrifice of the specificity of the possible diagnosis. Cortical superficial siderosis is the strongest predictor of bleeding risk. The safety of anticoagulating patient after CA-related ICH is still uncertain, but we'll get more data from Enrich AF, and I'd try to avoid it if possible. The International CA Association World Stroke Organization are working on clinical care guidelines for CAA, and I'm not able to say much more other than that what I'm telling you is either fairly consistent with the guidelines or I've identified where it's my own personal opinion. Hopefully these will be available for people to look at on the International CA Association website by the end of the year. I'll thank my research team as well as my collaborators. There is a international conference on CA that runs every 2 years. The next one will be in Banff, Alberta in September 2026. So I'd love to see you there. This is not far from where the current G7 summit is being held in a beautiful mountain location. And I'm happy to take questions for a few minutes if anyone has any, or you can email me at my email address shown there. Thanks a lot.
Hi guys, ask questions. There is a question in the chat.
Yep.
Do you see this question, Dr. Smith?
Yeah, I see that. The question is, how do we discriminate cavernomas from CAA, right? And okay, you're making it hard. So you're saying they're Hispanic too, right? Because the CCM mutations are more common in Hispanic families. So there are familial forms of CA are very rare, right? So there is a Dutch mutation, a Spanish mutation. They're rare enough that there's like a founder effect. They've arisen a few centuries ago, and you can almost trace the lineage back to the founders. So, if you do have a strong family, and the familial CA cases due to genetic mutations, onset of hemorrhaging is usually in the 40s or 50s, like with symptomatic hemorrhages. So, if there's a familial case with multiple microbleeds in a Hispanic family, like that to me points to the potential of a CCM mutation. It is challenging though, because like what some people call the type 4 cavernous malformations just appear as microbleeds, right? So you want to look carefully if there are the popcorn type lesions in addition to microbleeds. Well, that's the popcorn type lesions, which are larger ones that suggest multiple like rebleeds chronically in the same location. That's not consistent with CA. That would be consistent with a cavernoma. This is where there could be a role in the future for testing for a beta amyloid, right? So if you were to do right now, you'd have to do either an amyloid PET scan, CSF analysis for amyloid, but there are emerging plasma markers of amyloid and tau. If those amyloid markers are negative, and they have like a good but not outstanding negative predictive value, then you would say, well, I've excluded CA in this case, and it's probably a familial cavernous malformation. So that's the best we can do at this point.
Because I was a little bit interestingly, I did my training in New Mexico. So with Leslie Merson, I probably reviewed like 100 or 200 scans of familial cavernomas malformation. So they look so similar to CAA, and especially when it's widespread. So some patients recently, when I'm working in Texas now, so they came in, they were Hispanic, elderly, they had no history of any focal deficits or seizures. I don't have any genetic test, but I diagnosed them with CAA, but I was wondering what if they had like CAA. Couldn't find any popcorn lesion on FLAIR. So it's very interesting. How do you differentiate between two? Or they can also have CAA along with CCM. I mean, sometimes.
Well, yeah, exactly. There's no rule because CA is like pretty common, in the aging population. So, for example, seeing like multiple lobar microbleeds on MRI, incidentally, in the elderly it's not rare. It's like a few percent, right? Once you get in the 70s and 80s, right? So this is challenging. The other thing I've debated with people too, particularly if you have a population with a lot of in Central America, you have a lot of Central American immigrants, is neurocysticercosis, right? Like small neurocysticerci can have susceptibility artifact too. It can be helpful if you've done phase imaging to identify that they're calcifications, or if you have a CT. But sometimes multiple calcifications from neurocysticerci, you have to be a little cautious too, because they can appear as like multiple tiny susceptibility artifacts in the cortex. So be careful about that scenario as well. Maybe I'll move on to the next question if that's all right, which is then probably I should go actually because we're on the hour. But the question was a beta 40 and 42. Yeah. So if you look in the CSF, you'll find, and what you see in the CSF in both Alzheimer's and CAA is you see reduced levels of A beta. And the idea is it's getting stuck in the brain and not getting flushed out into the CSF is the way to think about it. So the CF levels are low, and the A beta 40 level is lower than A beta 42 in CAA. And that does discriminate between CA and Alzheimer's disease somewhat. It's the opposite with AD, like the A beta 42 level is the lowest. In the plasma, it's different though, and it's probably because there are peripheral sources of A beta production too. Like the brain is the only tissue that experiences like disease from A beta, but you can find A beta produced peripherally, like it's APPs expressed in platelet plasma membranes too, for instance. So this is the challenge. So in the plasma, we're looking at low A beta 42 predominantly. The A beta 40 is not that different between CA and controls.
Eric, can I ask one more question before you go?
Sure, go ahead.
I'm sorry I missed the beginning. I'm really intrigued by the fact that there's a treatment trial going on. So, I guess principally the concern right now with the monoclonal antibodies against amyloid, is causing ARIA. this is clearly a different approach with,
Yeah.
I guess, blocking RNA.
Yeah.
So do you see that this is principally about reducing the overall production of A beta? And I mean, I'm just curious, how is it staying localized just in the vessels, and how are we preventing any kind of complications that we're seeing in the Alzheimer's disease trials?
Yeah, yeah, that's the idea exactly, Sean. This rather than because triggering the immune system to try to clear vascular amyloid appears dangerous, based on what's been observed with ARIA in the context of lecanemab and donanemab treatment, right? So the inclusion criteria for treatment and the FDA label like exclude people who would have multiple microbleeds in CAA. So once you have a certain stage of CAA, you're very vulnerable to getting vasogenic edema and hemorrhaging, right? In this scenario, the mivelsiran is inhibiting A beta production, so it's going to limit the amount of new vascular amyloid deposition unless there's some sort of equilibrium between, clearance and deposition. The already deposited CA will probably stay there. I think most people believe it's not going to clear out amyloid from the vessels, but it will stay there. I guess the question is, like, by the time patients have multiple hemorrhages, is it too late? How much does reducing production at that stage make a difference in their subsequent course? I don't know. We will have to see. Like, this trial will hopefully answer that question, right? So other approaches to reduce amyloid buildup included small molecules to inhibit the beta secretase, but those worsen cognition for reasons that weren't clear in trials of Alzheimer's disease, or small molecules to inhibit the gamma secretase, which caused skin cancers. People don't like getting cancer, so that kind of killed that line of development. And those were both felt to be off-target effects because the beta and gamma secretase complex act on other proteins as well. So the new way to drop production is with these like very precisely targeted either small inhibitory RNA therapies or antisense oligonucleotides targeting the APP mRNA and stuff like that.
It's fascinating. It's great to know because, we have so many patients, obviously, and always telling them that we don't have any trials. So we hope this moves along so that we have something to offer in the next iteration of these trials that we hope will take place.
Yeah, there are multiple sites. It's global. There are American sites. I don't know if there are any sites in Texas. There is a website, capricorn-1.com, I think is what it is. So if you've got, because some patients are very motivated and there's nothing else to offer. I hope I got the site right, but so there might be a site in Texas. I'm not sure where. It's a bit of a challenging trial because they need to do intrathecal administration as well as some more cognitive and AD-like assessments, sort of turned off a lot of stroke sites from participating in the trials. So, but like, Mass General's participate, I'm participating. So again, not sure about Texas, but you could look it up. 2 sites at Dallas, somebody says. That's interesting. Okay.
Okay, great. Thank you
All
so
right.
much.
Thanks so
Really
much.
appreciate it. Thank you.
No problem. Have a good afternoon. Bye-bye.
Thank you.